but okay. I'm going to share my screen and we'll make a start. Okay. Okay, well, look, I thought last week's talk and the discussion was really useful, and I thought the questions asked at the end were useful. So I thought I would just go through some different types of common pediatric problems for which there is some intensive care management required. And this is not to teach you so much about intensive care, but about how to look after like critically ill children in all our settings. All right, so we'll make a start. I wanted to talk to you. I'm really going to talk to you about, I'll just let a few people in, but I'm going to talk to you about just some cases that I've seen just recently, and I think they illustrate some really common, some issues that are common to all of us actually. And I just thought I'd share with you these cases, some of which from PNG and some of which are from Melbourne. They're a mixture of severe cases, and they illustrate some areas about how to manage seriously ill children. I just have to admit a few people. There's more and more people coming in line now. But this was the first case I wanted to talk to you about, because I want you to be able to interpret X-rays really well. And sorry, I'll just admit a couple more people and maybe wait a half a minute until everybody gets on. Okay, well, I think everybody's online now, so we might make a start. As I said, I wanted to talk about the management of some critically ill children, and there's some things you can do in your own settings to manage these patients well. The first case, I also want you to be able to interpret X-rays well, because I think there's some subtleties to the interpretation of X-rays that can really help you in understanding what the underlying diagnosis is and the pathophysiology, and then understanding what sort of treatments can be applied and might be useful. So this was a 9-month-old child who I saw recently. She had 2 days of cough, fever and respiratory distress. So she'd been previously well. Apart from when she was 7 months old, she had an episode of severe egg allergy, and she'd been given some egg by her mother, and she developed severe wheezing and a rash. But apart from that, she was well, and she was a well-grown child. But she presented with, I'll just admit a few more people as we go. She presented with severe respiratory distress and a moderately high fever, about 38.5, and a cough for 2 days. When she presented, she had really severe chest indrawing, very severe respiratory distress, a heart rate of 170 to 180. It was even going up to 190 at times, and she was quite hypoxic with a saturation of 82%. And on clinical examination, she had a very prolonged expiratory phase and lots of wheezes and
How can she have a respiratory of 80 and prolonged respiratory?
I'm sorry? I wonder what you could see. Can you see anything in the X-ray? What can you see on the X-ray? Could someone suggest what you can see on the X-ray?
It's off now.
When we're looking at an X-ray of a child with severe respiratory distress, we're often looking for consolidation, aren't we? Yeah. But can you see any consolidation on this X-ray?
No.
There's not much, is there? You might say there's a little bit of patchy change in the right lobe, but you can see the right heart border very clearly. So I don't think that's that's consolidation. But there is some striking features about this X-ray.
I think these are hyperinflated lungs.
Yes, this is a markedly hyperinflated lungs, aren't they? Both lungs are hyperinflated, especially the right lung. You can see how flat the diaphragm is, how pushed down it is. Both diaphragms are flat, and you see that the lung fields themselves look quite black. There's not a lot of lung markings. So this is a child who's got marked hyperinflation. So I want to go back to the way we manage children. And remember that the stages of management of any sick child is, if you think about these stages, then you'll be able to manage every child. We should have a triage, provide emergency treatment, take a history and do an examination, incorporate some laboratory investigations, have a main diagnosis and then other diagnoses if they exist, provide treatment, then supportive care and monitoring, and then discharge planning and follow-up. And if we think about that for every patient who's seriously ill, then you won't miss any steps. At triage, you need to take a brief history of the presenting problem. Just like I said, 2 days of fever, cough, and respiratory distress. And then I think the triage process really should take you no more than a minute or two. And if you get good at it, if you start doing triage on a lot of patients and assessing them quite quickly, then you can work out which ones have emergency signs or not. And this triage process really takes a couple of minutes to take the temperature of the child and weigh the child. If the child's stable enough, you can listen for stridor or obstructed breathing. You should look for cyanosis and other signs of respiratory distress, and check the oxygen saturation. And then you feel the skin of the hands and the feet. I always feel the hands and the feet and feel the pulse, check the capillary refill time, and feel whether the hands and the feet are warm or cold. And then while you're doing that, you can assess for lethargy and the level of interaction. That's all you need to do at triage, because if you do all of those things, I'll just admit some more people, if you do all of each of those brief steps, that brief assessment of the patient, then you can identify all the emergency signs you need to, involving the child's airway, breathing, and circulation, and their conscious state. So this child had some signs, some emergency signs, had obstructed breathing, seemingly obstructed breathing with marked wheeze and prolonged expiratory phase, had severe respiratory distress, and was hypoxic, saturations of 82. So you would say that this child had at least 3 emergency signs. You only need to find one, and then you should provide emergency treatment. So what sort of emergency treatment would you provide for this child?
Put the patient on oxygen.
I think someone said put the patient on oxygen. Is that what you said, Benji? Yes, you'd provide oxygen. You might give salbutamol, you might give some Ventolin, and you'd probably give antibiotics in a child who's got such severe respiratory distress. But basically, oxygen and salbutamol are the key treatments. When we gave salbutamol to this child, the child became very tachycardic and very irritable and distressed. So the question is, what else can you do? Can you think of anything else you could do?
Would you nebulize adrenaline?
Yes, you could nebulize adrenaline. In what children is nebulized adrenaline very good for?
Croup.
Yes, it's mostly for croup, isn't it? It also has a role perhaps in the most severely ill patients with bronchiolitis. What do you think's wrong with this child? When you look at this child's X-ray and hear the story, it's a 9-month-old baby with this X-ray. What do you think's likely to be wrong?
Probably have air trapping.
Yes, that's right. The child has severe hyperinflation and air trapping. And what could be the diagnosis?
Severe bronchiolitis.
Yes, this is severe bronchiolitis, isn't it? This is with severe gas trapping from bronchiolitis. And so what sorts of treatments might be useful for children with severe bronchiolitis? We talked about oxygen, salbutamol, although sometimes it causes children to be very tachycardic and distressed. What other treatments might be useful in severe bronchiolitis?
Around nebulization and probably CPAP as well.
Yes, so someone suggested that nebulized adrenaline might be useful, and sometimes it is. Sometimes nebulized adrenaline is useful, and sometimes for some patients, I'll just there's a couple of other things just before we get onto the treatment. There's a couple of other things that could cause such hyperinflation. You got it right, the bronchiolitis, but there's a few other things you should think about. So could this child have asthma?
Usually we diagnose asthma in kids above 2 years.
That's right, usually above 1 or 2 years. But does that mean the child won't respond to Ventolin or bronchodilators?
He would, like, it would be more like a reactive airway.
Yes, I mean, I think the point is you're making that we don't diagnose asthma until the child's certainly over a year or sometimes 2 years, but sometimes babies that are getting towards a year of age can still respond to some bronchodilators. They still have some reactive airways disease that will enable them to respond to bronchodilators. Not always, and it's very different for babies who are, you know, it's 1 to 6 months. They almost never respond to bronchodilators, but babies who are 9 to 12 months can sometimes respond to bronchodilators. There's a couple of other things that I'll mention a bit later that might cause such severe gas trapping. But as I said, this child became very distressed and tachycardic with salbutamol and had severe respiratory distress despite giving oxygen, had lots of wheezes and crackles. So what else could you do? Well, salbutamol caused tachycardia. Someone suggested before CPAP. That can be useful in babies who've got severe bronchiolitis. Someone suggested adrenaline. Benji, you suggested adrenaline. Giving steroids can be useful only if the child is responding to bronchodilators. It's of no use in the younger children that don't respond to bronchodilators, but in the older child that responds to bronchodilators, then I usually give them steroids. So a trial of bronchodilator therapy with salbutamol or Ventolin and steroids can be useful. What about nebulized saline? Do you think that's helpful?
Yes.
It can be helpful, can't it? It's not, all of these therapies are not always helpful, but I guess the point is to decide which patients that they might help and give a trial of that therapy if they're very severely unwell. What about magnesium? Do you think that might help? Have you heard of using that? The reason I mention is because that's the therapy that I gave to this child and it worked very well. And I'll explain why that might help in some children who've got some types of bronchiolitis. But let's go through. There's a lot of trials of using what we call hypertonic saline. So that's 3% or 6% sodium chloride in babies with bronchiolitis, hypertonic saline. But what's the percentage of the saline that we normally have? What's the percentage? What's normal saline in terms of percentage?
0.9.
Yes, 0.9, that's right. And so all the trials in bronchiolitis have been done with, or most of the trials have been done with a hypertonic saline, which is about 4 times as concentrated. So 4 to 6 times as concentrated. And they've all shown a benefit for some children, not all children, but mostly. And mostly hypertonic saline helps infants shift their secretions when they block their airways. So you see the babies that are having, they feel that it seems like their lungs are full up of secretions, and they get very irritable, and they block their lungs with mucus and secretions, and that causes them to be hypoxic. And for some of those children, then hypertonic saline can work. And I just wanted to, for some of you will know about this study, but Dr. Gordon Pukai, who might be online, I'm not sure, he did a study, a very good study of just using normal saline in bronchiolitis. And that was a randomized trial. It's the only trial that has looked at normal saline. There's many other trials that have looked at hypertonic saline, but he used what was available, and Gordon used normal saline. And so he randomized 199 patients with bronchiolitis or moderate pneumonia who are under 2 years of age to either normal saline or just standard care, which was oxygen and antibiotics. And children in both groups got oxygen and antibiotics, of course. And what he found was that their respiratory distress improved at 4 hours. So he only monitored patients for the first 4 hours and until they went home from the children's emergency department. They had improved respiratory distress, and they had the improved oxygen saturation, significantly improved both. And they were more children who received normal saline were able to be discharged from hospital in a safe way. They didn't return later on, being very sick. So it seems like even using normal saline helps some children. But again, these therapies that I've mentioned, they don't help all children with bronchiolitis. They only help some children. So sometimes hypertonic saline will work. Sometimes normal saline nebulized will work. Sometimes salbutamol will work in some older children. And in some children, I wondered whether magnesium might help. And I'll just explain why. Magnesium is very good for children with asthma. It's not the primary therapy, but if you've got a child who's got severe asthma and you've given them salbutamol and you've given them steroids and you've given them aminophylline, then the next thing that I think works well is magnesium. In fact, I use magnesium these days before I use aminophylline in most children. And that's because it's a bit safer for children than aminophylline. Magnesium has a lot of different mechanisms by which it inhibits the contraction of bronchial smooth muscle. And as you know, in asthma, you've got bronchoconstriction. The smooth muscle of the airways is contracting, and magnesium inhibits several pathways to bronchial constriction. I won't go through them, but there's 3 different pathways that cause bronchial constriction. And also magnesium has an anti-inflammatory effect. So it reduces mucus production, it reduces histamine release from mast cells. So if you've got asthma, many of those patients have a lot of histamine as a stimulating factor to their bronchoconstriction, and it can reduce neutrophil activation. So it's been shown now to be quite effective in asthma, but actually it's not proven in bronchiolitis. In fact, in most children with bronchiolitis, it doesn't work. But the reason I thought it might work in this child is because of the history. And again, the history is very important. This was a baby, if you remember, at 7 months of age, been previously well, was growing well, but at 7 months of age had what was seen to be egg allergy with a marked wheeze. And the family also had a strong history of asthma in the family. And so I thought maybe magnesium might work because salbutamol was making the baby very tachycardic, and it did. So the dose to give is 0.2 mils per kilogram. So magnesium comes as 50% solution, or it's 49.5% solution, I think, but essentially 50% solution in a vial, and you give 0.2 mils per kilogram. You give it slowly over 30 minutes. The only thing that can happen is that sometimes you get some vasodilatation and the blood pressure drops a little bit. But most of these children have a high blood pressure because they're distressed and very stressed by their hyperadrenergic state, by the stress of their respiratory distress, and they're actually hypertensive. So it can sometimes calm them a little bit as well. So I use, for children with asthma, and for older children with bronchiolitis. Sometimes, if they've got a family history of asthma, then using some magnesium can help. And it was very effective in avoiding this child needing to have mechanical ventilation. Okay, now I just wanted to go through a couple of other X-rays that are a bit similar to the one I initially showed you. And these are some children that also presented with severe respiratory distress. And can perhaps anyone comment on what the X-rays, these X-rays show? The X-ray on the left was a baby in Port Moresby from a couple of years ago who had severe respiratory distress. I thought it was a very useful X-ray because it shows, what does it show? Come on, can someone suggest what it shows? It looks a little bit like the mediastinum is moved to the right side, doesn't it? It looks like the mediastinum is moved across to the right side, but why is that?
Pneumothorax of the right lung.
Yes, you might think it's a pneumothorax, and that's what I think people did. But you mean of the left lung, Eleni? You mean of the left lung? Oh, no.
Left lung, yes.
Yeah. Sorry, maybe you're talking about the other X-ray. In fact, it's like they're mirror images of each other. These are different patients, but they have the same problem. And I think it's useful if we can understand this problem. And you might think that this one's a pneumothorax of the left lung, and perhaps this one might be a pneumothorax of the right lung. But in fact, what they are just hyperinflation of one lung. And I think in both of these patients, both lungs have hyperinflation, but they just have one lung that's more dominantly hyperinflated. And I think that's what you're seeing is both lungs are well inflated, but in this X-ray, the left lung is over distended, and this is the margin of the left lung pushing all the way across to the right side, and that's what is pushing the mediastinum across. And in this one, the right lung is hyperinflated. This up in the upper zone, there's collapse, but it's one lobe that's over distended, right? A markedly over distended right lung. The left lung is also in this X-ray is over distended as well. What could cause this?
Could be a complication of pneumonia.
It could be a complication of pneumonia, but can you see any pneumonia? Is there any consolidation on the X-ray?
No.
No, there's not consolidation, is there? There's just markedly over-distended lungs. And you can get that because of, I mean, asthma can give you over-distension of the lungs like this, that's possible. And a few other conditions can do it too, such as if you had some airway obstruction, if you had a ball valve obstruction of the bronchi. But actually, both these children had the same problem. They just had RSV related bronchiolitis. That's what they had. And they had a background history of asthma. They were both young infants, like one's 9 months and the other one, I think, was even a bit younger. And they both had just bronchiolitis. But that can give you such over distension of the lung. A congenital abnormality causing an obstruction of one airway could give you over distension, but when you see both lungs being over distended, then it's more likely it's a diffuse problem that's causing over distension. And again, it's useful to recognize this because we often don't. We look at a child with severe respiratory distress and we say that they've probably got pneumonia, but sometimes there's different pathophysiology going on. So I want you to be able to recognize over distension on an X-ray. Okay, so hyperinflation over distension, right? I'm just going to go on to the next case now, which was a complicated case, and I just want to explain it in a little detail. This was a 2-year-old girl who presented with 3 days of cough, fever, and respiratory distress. And she had a history. Remember, the history is very important. She had a history of stridor. So she had what sounded like upper respiratory noises every time she ran. And she'd been, she'd been walking since she was 12 months of age. So her grandmother told me that she had, every time she ran around, she got stridor. And so she otherwise had been quite reasonably well, although she was failing to thrive. She wasn't gaining very much weight. And she presented with just 3 days of cough, fever, and respiratory distress. And she presented just last week with severe respiratory distress and lots of crackles in her chest, and was very cyanosed. And she too had a very prolonged expiratory phase. What do you see on this X-ray that's different to the other ones?
There's no air trapping. It's more haziness, a consolidation on bilateral lung fields.
Yes, that's right, Tina. Yeah, that's exactly right. There's not air trapping, at least not what you can see on X-ray, but there is general patchy opacities, particularly in the upper zones, isn't there? Yes. So this is different to the previous X-rays I showed. Even though the presentation is the same, the X-ray appearance looks quite different. There looks like there's a diffuse patchy opacity in both lung fields. All right, very different to this X-ray where the lung fields look black and there's marked hyperinflation. Right. Can you see anything else on the X-ray?
So the opacities are more concentrated on the mediastinum area, and there's also a hypodense, well demarcated hypodense secular in the tracheal region.
Yes, very good to focus on the mediastinum, because there does seem to be a sort of more widened mediastinum, or there's patchy opacity, isn't there, in the para-aortic mediastinal area. And what, Glanson, what were you saying about the airway shadow? I think you were saying something about the tracheal shadow.
So I think I saw a well-defined hypodense area, what actually is secular. Not sure if it's compressing from outside.
Yeah, very good. Yeah, so this is an endotracheal tube, of course. This is the endotracheal tube. And usually, I'll just show you the other X-rays. Usually when you can follow the trachea down, you can see the trachea. It's a little bit harder in this one, but you can usually see the trachea down a lot further. Whereas this one, where can you see the trachea down to? Just the endotracheal tube. And then what happens is you can see how it looks like it narrows down. Yeah? You can see that? So what I want you to get used to having a look at the tracheal and the bronchial shadow, and you usually can follow the trachea down to the carina, and then you see the separation of the carina into the left and the right main bronchus. But it's very hard to see, isn't it? And what could cause that? Sometimes you might think, oh, because there's lots of consolidation there, then that's why you can't see the trachea and the airway. But that's actually wrong, because if there's consolidation in the alveoli, you should see the air bronchograms and the air tracheogram even better. It should be even more outlined. So all of this, what looks like consolidation here, should better outline the trachea. But in fact, it doesn't, does it? The trachea looks like it comes to a narrow point. So what could be causing that?
So it could be an obstruction, like a mediastinal node obstructing the trachea.
Yes, very good. It could be something causing extrinsic compression of the trachea, such as like a mediastinal node. And you could imagine that there could be quite a number of mediastinal lymph nodes in this area causing obstruction to the trachea. That's very good. Well done. Can anyone think of anything else that might cause that? This girl had been thought to have laryngomalacia in the past, but actually her larynx looked normal. What other forms of malacia could lead to this type of X-ray appearance? Laryngomalacia is a floppy larynx, but you can have malacia. Malacia just means soft or floppy, doesn't it? What else? What other parts of the airway could have malacia?
Trachea.
Yeah, good. She could have tracheomalacia, and that could give her stridor every time she runs. And so I wondered whether she might have tracheomalacia. That's what I wondered, whether she might have tracheomalacia. And the tracheomalacia, she may well have pneumonia on top of tracheomalacia. And so I wondered if she was thought to have laryngomalacia. Someone thought she might have asthma because every time she ran around, she got stridor or noisy breathing. It wasn't exactly clear. Some children can have recurrent croup, can't they? Recurrent upper airway obstruction. That's unusual, but sometimes children can. Pneumonia on top of tracheomalacia. What about an inhaled foreign body? Could that be the problem? An inhaled foreign body leading to this?
With the inhaled foreign body, there'll be air trapping.
Often there will be, but sometimes often there will be, but sometimes with an inhaled foreign body, you'll get, if it's been there for some time, then you'll get areas of collapse, or you'll get secondary pneumonia because of the inhaled foreign body. So you're right, an inhaled foreign body can give you two X-ray appearances, one collapse and pneumonia, or the other one air trapping and hyperinflation. So either one would be correct. I mean, I've seen a tracheal foreign body, a foreign body in the lower part of the trachea, just sitting at the carina, leading to pneumonia. That can cause quite severe obstruction, just like tracheomalacia, just like lymph node compression of the trachea. In a child, for example, who has we've talked about in past sessions, we've talked about a T-cell lymphoma. So a T-cell lymphoma from the thymus can lead to obstruction of the trachea. So something else that might do it. So there's a number of things that might do it. How could you possibly sort it out? It's hard to distinguish between all of these. Is there any cardiac problem this child could have? We don't usually see a cardiac problem presenting with stridor, but sometimes a cardiac problem can be associated with tracheomalacia. That's a bit different to what this child had. I wondered if this girl might have a cardiac problem. So we did an echo, and that was suggestive of a cardiac problem. The heart itself was normal, but it was suggestive of a cardiac problem. And then I'll just tell you, she went on to have this. Oh, I want to show you this. I want to show this because when we see children who've got obstruction, airway obstruction, just watch this. Can anyone see what's wrong? I'll show you it again. What's the main abnormality there?
Tachycardia.
Yes,
Yeah.
there is tachycardia, that's true, but is there something else going on? Something that's a bit unusual. We're used to seeing tachycardia a lot, but there's something we don't always observe, we don't always notice this, but I want you to notice it in the future. I want you to look at this is the arterial waveform, and this is the oxygen saturation. We're used to looking at oxygen saturation. Just look at this is called the plethysmographic trace. What is it about the plethysmographic trace that looks a bit abnormal? I'll show you again. What is it about the oxygen saturation trace that looks abnormal? Well, it goes in waves. You can see how it goes down and then it goes up and then it goes down and then it goes up and then down again. You see that? Just watch again. Normally you won't see this, but can anyone tell me what it tells you? If you see this in a child when looking at the oxygen saturation trace, what does it tell you?
Probably an indication of when the child exhales and inhales,
Yes.
oxygen concentration.
Yes, exactly right. And what happens when the child exhales compared with inhales? Which one is the child inhaling and which one is the child exhaling?
Oxygen saturation, this one.
Yeah.
So oxygen concentration, saturation increases when the child inhales.
Okay, yes.
Probably decreases.
Yeah, it does. And I want you to I want to know why. And so I want you to look at this is the blood pressure, and this is from arterial line, and you can see the blood pressure goes up when the child inhales, the blood pressure goes up, and then when the child exhales, the blood pressure goes down. Just watch that one. You see, goes down, goes up, goes down again, up, down, up. Right. So what's happening? Why does that happen?
Probably something compressing on the aorta.
Yeah, it could. It's sort of like that, Alan. Yeah, it's a little bit like that. But and you could see that if there was something compressing the aorta. It's a little different to this. And what this illustrates is what you see in a child who's got severe airway obstruction, some sort of airway obstruction, and it can be from any cause. It could be from severe asthma. If you see a child with an oxygen saturation trace that goes up and down like that, and they have severe asthma, we call it something else sometimes. What's the feature you used to calling it another name? The blood pressure goes up when the child inhales and goes down when the child exhales. What's that called?
Pulsus paradoxus.
Very good. Yeah, pulsus paradoxus. And what I'm showing you here is an illustration of pulsus paradoxus. And you can see how the oxygen saturation goes up on inhalation and goes down as the child exhales, and then goes up again. And the same with the blood pressure. The blood pressure goes up when the child inhales and then goes down when the child exhales. And why does that occur in pulsus paradoxus? I'll tell you. Eleni was a bit. Oh, sorry, Tina, you're going to say something? Oh.
Constrictive or restrictive disease?
Yeah, it's a little bit like that.
On the
on what?
On the heart.
Yes, that's right. So when you have severe airflow obstruction, like if your child's got severe asthma or severe bronchiolitis or severe croup, any form of severe airway obstruction, when the child breathes in, then the intrathoracic pressure it's lower. It's lower. When the child breathes in, the intrathoracic pressure is lower because the child's taking a breath in, and when they breathe out, then the intrathoracic pressure increases because they're having to breathe out forcefully. They have to breathe out forcefully to get to be able to breathe out properly because they've got airway obstruction. So that increases the intrathoracic pressure when they breathe out. And when you increase the intrathoracic pressure, that reduces the venous return to the heart, and therefore the blood pressure drops, and therefore the oxygen saturation trace changes with the blood pressure, right? But when the child breathes in, the intrathoracic pressure goes down and their blood pressure can come up again because their heart fills easier. So that's the reason for pulsus paradoxus in asthma, and you can see it sometimes on the oxygen saturation trace, right? I just wanted you to see that because I think we see it a lot, but maybe we don't always notice what it means. And I want you from now on to be able to notice it on the oxygen saturation. That's what you're seeing is a pulsus paradoxus. If it clearly has this phasic oxygen saturation that goes up and down with respiration, just with respiration. Okay. Now, so after that, I thought most likely this child had some sort of compression of the airways. I thought, like Tina, I thought maybe there's some lymph nodes or something like that compressing the airways, or some other heart problem compressing the airways. And this is an uncommon heart problem, but I just wanted to explain it. This is what's called a vascular ring. So this child had what's called a vascular ring, or a PA sling, a pulmonary artery sling. So normally the pulmonary artery comes out of the right ventricle, of course, and then divides off into the left pulmonary artery and the right pulmonary artery. But in this child's case, the left pulmonary artery came from the right pulmonary artery. So instead of dividing here into left and right, the right comes out and then the left comes off it. And then it's slung around the trachea. This is the trachea, the black area there. And you can see that there's this sling tying, almost like tying the trachea around. And what was happening was that this child's airway was narrowing because of the blood vessel that was constricting the trachea. So there's a couple of different ways in which you can get a heart problem or a vascular ring that wraps around the trachea, but that's what this child had. And she's subsequently gone on to have a division of that and a refashioning of the pulmonary artery, and she's fine now. Her trachea is normal. So I want you to be able to think of the different causes of a compressed trachea. Of course, a pulmonary artery sling is a rare cause, but other causes such as tracheomalacia or an inhaled foreign body or extrinsic compression from lymph nodes or some other cause like that are more common. But also think of a pulmonary artery sling or a vascular ring that's wrapped around the trachea, or some other mass in the chest like a thymic mass. Okay. All right. Now, I just want to show you one other type of case. We've got time, haven't we? Yeah. So this was a 4-month-old boy who had failure to thrive. He'd been failing to thrive for about 2 months. And he also had persistent diarrhea. And he presented with respiratory distress and fever and tachypnea. So similar to the previous cases. And he had oxygen saturations that were very low, so saturations of 65 to 70%. Even when giving oxygen, they only came up a bit. He had a high fever and a respiratory rate of 70, and again tachycardia, a bit similar to the previous cases. That was his full blood examination, and he of course got treated with oxygen. What do you see on his x-ray? What can you see? There's something a bit different. I've shown you a few different types of x-rays, one with hyperinflation and gas trapping, another one with tracheal compression, and this one has a third abnormality which we don't always detect. So what is on this x-ray?
I think
Intestinal?
I'm sorry, what's that? Say that again.
Air in the mediastinum.
Yeah, very good. Very well done.
yeah.
This baby has a pneumomediastinum, isn't it? Yeah. Can you see a pneumothorax?
No.
No, I can't either. And I think it's a useful case because some children present with air leak that's not a pneumothorax. Well, you get used to thinking of air leak as being a pneumothorax, but this baby's got air leak in the mediastinum. Where else has the baby got air leak? Where else? There's air up here, isn't there? There's air where there shouldn't be air up here. So where would that be? If you looked at the baby, what would you see?
Subcutaneous crackles.
Yes, that's right. Yeah, the baby's got air in the neck and air in the jaw or the face, and so this baby has a pneumomediastinum with subcutaneous emphysema. All right, and so when we again another type of X-ray appearance that we don't always detect, often that it gets detected sort of rather late, but it can give you a really good clue as to what the cause is. And so what might cause this type of X-ray appearance?
It could have a fistula.
Yeah, very good. What sort of fistula could it be?
Sure, somewhere in the trachea up by away.
Yeah, usually tracheoesophageal fistulas will cause air to go from the trachea into the stomach, and so you don't usually get a pneumomediastinum unless, of course, the fistula perforates, and that sometimes happens, or the esophagus perforates, and then you'll get pneumomediastinum. But the other type of fistula that can sometimes cause a pneumomediastinum is if you get a traumatic fistula where you've got for example, if a child has a trauma to the larynx. You know, sometimes in rugby games, for example, you can get trauma to the larynx, and that can lead to the tracking of air outside the trachea. And in some traumatic injuries, such as if a child falls on like the handlebars of a bike, then sometimes you can get a traumatic injury to the larynx, and that can lead to a leak. So that's possible, yes. But there was no history of trauma in this child. So what else might lead to such a pneumomediastinum and subcutaneous emphysema? Okay, well, air leak, so pneumomediastinum or subcutaneous emphysema, can be anything that causes a sudden increase in intra-airway pressure. All you've got to do is have a marked increase in intra-airway pressure at any point in time. So sometimes you see a pneumomediastinum in children who've got severe asthma. They can just suddenly, because of their airflow obstruction, lead to the rupture of small alveoli. And so asthma or a foreign body or a bout of heavy coughing. If you've got a child who's got severe pertussis or RSV or pneumocystis, then they can, because of a bout of heavy coughing, that can lead to an increase in intra-airway pressure that just leads to a rupture of an alveoli, which can lead to a pneumothorax or a pneumomediastinum. And any problem leads to airway fragility, like if you've got a cyst or a bleb or some sort of fragile airway, such as with tuberculosis or pneumocystis, that's typical for as causes of a pneumomediastinum. And this child, and so this child I showed you here, and this child here have the same problem. They have exactly the same problem. What can you see on this child in this one? What's different?
Just a pneumothorax?
Yes, that's right. This baby, This baby got a pneumothorax. And which side is the pneumothorax, Benji?
I think both sides.
Yes.
More on the
Yes. Yes, maybe it's more on the right side than the left, but it's certainly both sides, isn't it? There's a pneumothorax here, and you don't see the lung collapsed. And when you do the X-ray appearance, when you don't see the lung collapsed like that, what does that tell you? It's a bit collapsed, but it's not very collapsed. What does it tell you?
I think it's just there's still good extension of the lungs. It's just on the edge.
Yeah, you can see that. If you can see my cursor, you can see the pneumothorax is there, but the lung hasn't really collapsed. It's sort of stayed somewhat inflated. And the reason for that, if you see this and the lung is not collapsing, then you should think that there's probably significant consolidation of that lung. And the reason it doesn't collapse is because it's rather consolidated. And that's the case in this child. And this child and the one I showed you before have the same problem. And I want you to be able to recognize it, because if you see a child who's got severe hypoxia, remember the child's saturations were 65 to 70. If you see an air leak of any sort, whether it's a pneumomediastinum or subcutaneous emphysema or a pneumothorax. Now, I showed you the full blood examination of this child before, and when you look at the full blood examination, the hemoglobin's normal, the white cell count's normal, the neutrophils are normal, but the lymphocytes are very low. And when you see that combination with severe hypoxia, air leak, lymphopenia, and especially failure to thrive, then that adds up to most likely pneumocystis. And this baby, this one here, and this one both had pneumocystis pneumonia. That's a typical X-ray appearance of pneumocystis pneumonia. We get used to pneumocystis being this sort of diffuse bilateral fluffy opacity, and mostly it is, but sometimes it can present with severe air leak as well. There are some other causes of air leak, like RSV infection. You can get air leak like with pneumocystis with RSV, or some trauma. And I've seen both of those recently, but think when you see this combination, hypoxia, air leak, lymphopenia, and failure to thrive, then think of pneumocystis. Air leak can also occur in other conditions, like I said, and this was a child who just had asthma, who had severe air leak. And this is the worst, one of the worst types of cases of air leak I've ever seen. And you can see, where's the air in this child?
Most of it in the subcutaneous tissue.
Yes, that's right. Most of it's in the subcutaneous tissue. I mean, this was massive subcutaneous emphysema in a child who had asthma, and as I said, all it takes is in asthma where you have marked increase in intra-airway pressure. If the patient is very obstructed from their asthma, then they can get they can rupture some alveoli, and that leads to both pneumothoraces and also severe subcutaneous emphysema. It's sometimes people looked at this and said it's a bad X-ray. Well, it's not a bad X-ray that's all fuzzy because the patient moved. It's simply that there's massive subcutaneous emphysema. This was another child who it's a little bit more, it's more subtle, of course, but I want you to be able to see the subcutaneous emphysema in this child. And can anyone see where the subcutaneous emphysema is? It's tracking up here, you see? You see that the pneumomediastinum and the subcutaneous emphysema. And this child had a very distended neck. And this was a child who had tetanus. And the reason he had subcutaneous emphysema was because he'd had a tracheostomy. You might be able to see that little tubing there. He'd had a tracheostomy for his tetanus, and he had quite a large leak out of the tracheostoma. There was a bit of a leak, and because he was having chest wall spasms from his tetanus, then every time his chest wall went into a spasm, the pressure in his airway went up, and that caused him to leak a bit of air in the subcutaneous tissue. So once his spasms were under control, he stopped leaking air through the subcutaneous tissue. So the point is, understand, look for signs of air leak in children who've got severe respiratory distress. Look for pneumomediastinum, look for subcutaneous emphysema or pneumothoraces, and then if they've got any air leak, then think about, well, why might that be? And you can think, well, they probably have some increase in airway pressure, like they've got severe obstruction, and they may well have some damage to the alveoli that's led to the leak of air. Okay. I mentioned that this boy had lymphopenia. The boy with pneumocystis had lymphopenia, and I think it's useful to understand what lymphopenia is. The normal lymphocyte count is age dependent, and as children get older, then their lymphocyte count actually gets lower. So if you're over a school-age child from 6 years of age older, then the normal lymphocyte count is 1,500 and above. But if you're in the first 2 years of life, then you should have about 3,000 lymphocytes. Now, the commonest reason for lymphopenia is not pneumocystis. It's just another viral infection like RSV or some other virus infection. But sometimes when you see a child with lymphopenia, you should think, well, maybe they've got an immunodeficiency like pneumocystis, especially if they're like HIV, especially if they're failing to thrive. So in any child with lymphopenia, I always make sure I repeat the FBE, the full blood count, again in 1 week time, because in a week's time the lymphocyte count should have resolved. And so you should get used to looking at the lymphocyte count in your patients and seeing if it's low. And if it's low, you don't need to do anything about it unless they've got other signs of immunodeficiency or something. But I always think it's useful to repeat later, 1 week later, and just make sure that the lymphocyte count is resolved. Okay, right. I was going to talk about this patient who I think is interesting. I will, just if you've got time, we'll talk about this patient. This was I've been talking mostly about severe respiratory distress, and so we followed a theme of severe respiratory distress, but I wanted to talk about this patient because he was a 12-year-old boy, and he collapsed and needed CPR while he was at soccer. He was just at soccer training. He was 12 years old and he was previously quite well, and he had a sudden collapse, and he wasn't struck or knocked or anything. And his father was there and he gave him CPR, and then an ambulance arrived and they found this rhythm. I want you to see what does this rhythm show? In some ways, the rhythm looks a little bit like I showed you before with the arterial trace, doesn't it? But it's different. It looks the same, but it's actually quite a different problem. What is this rhythm?
It's an SVT.
It could be SVT, but when you've got SVT, then what will you typically have? Like you'll be able to see the QRS complexes, and they'll look normal, won't they? They'll look like normal QRS complexes, but they'll be so this is not. Can you see? There's nothing there that looks to me like a normal QRS complex. So it's not SVT.
I think it's a polymorphic ventricular tachycardia. Could be a VF or a pointed VF, ventricular fibrillation.
Yes, that's right, Simon. Yeah, this is ventricular fibrillation, and can anyone? This is a particular type of ventricular fibrillation, and it has a particular name. Does anyone know what it is? And it's the name of it is related to this flowing up and down motion of the it's not an artifact of the way it's collected. It's getting bigger and smaller, bigger and smaller. What do you call that?
Polymorphic VT.
Yeah, polymorphic VT. Yes, that's right. It is that, and it has a particular name. It's called. Sometimes people think it's like the ABC symbol, but it's
torsade de pointes.
Very good. Torsade de pointes. Torsade de pointes. And that's what it is. It's torsade. And if you can, once you've seen this one time, you'll never forget it, because this is the characteristic of torsade de pointes. And does anyone know who said torsade de pointes? What's usually the cause of torsade de pointes? Does anyone know? You've heard about it.
It can be caused by electrolyte imbalance, where you have prolonged QT, which then develop into torsade.
Very good.
So hypokalemia, hypomagnesemia.
Yes, very good, Simon. It sometimes is related to severe electrolyte imbalance, particularly hypomagnesemia. Yeah, a very low magnesium, and sometimes hypokalemia, and sometimes it's related to prolonged QT interval, and sometimes it's related to another condition called Wolff-Parkinson-White syndrome, isn't it? So Wolff-Parkinson-White can give torsade de pointes. And in this child, I wondered if he might have Wolff-Parkinson-White syndrome. So how would you detect, what is Wolff-Parkinson-White syndrome? I'll show you his ECG, because this is just a rhythm strip, and to know what sort of rhythm the child's actually got, it's helpful after he was defibrillated to look at his ECG. And so this is his ECG. All right, I've given it away by the circle around it, but what can you see on the ECG? On the ECG?
I think you're looking for a delta wave.
Yeah, very good, Benji. You are. Very good, Benji. You are. And can you see a delta wave?
Yes, there's delta wave and shortening of the PR interval.
Exactly.
Yeah.
So exactly. So what does that confirm the diagnosis as?
WPW.
Yeah, WPW.
This boy's got Wolff-Parkinson-White syndrome. He was previously quite well, and then he just went into sudden torsade while playing soccer. Yes, that's right. And when he presented, he was severely hypoxic, and he was quite hypertensive after he was defibrillated. What does the chest X-ray show? What do you think it might show? you might look at the X-ray and say, say he's got pneumonia. Say, you were going to say something?
I just think the ribs look a bit crowded, but I'm not too sure.
Yeah, no, the ribs are okay. No, there's something else. This child's got pulmonary edema, and he has pulmonary edema just from his arrest and the consequences of having an arrest and then being defibrillated. So you could look at it and say he's got pneumonia, but he was well until he had the sudden arrest at playing soccer. And the other thing is he could have aspirated, which is also possible. It's possible he's aspirated, but most likely this is simply acute pulmonary edema related to him having an arrest. And so sometimes when a child's had an arrest from this type of arrhythmia, they'll present with pulmonary edema, and usually it resolves quite quickly if you give them oxygen and some positive pressure. So this child was treated with CPAP with 100% oxygen to start with a magnesium infusion because Simon, I thought maybe he's got severe hypomagnesemia, and magnesium helps to stabilize torsade. If you've got torsade or a severe arrhythmia, then magnesium can help to stabilize it. So I've talked about two possible uses of magnesium today. One is for children with severe asthma, and the other one is for children who've got torsade or polymorphic ventricular tachycardia. And it doesn't help if you've got acidosis or hypokalemia, so it's important to correct the electrolyte abnormalities and correct the acidosis, give some magnesium, give some antibiotics because he might have aspirated when he had the arrest, and then just wait for time. And really within about 8 to 12 hours, he improved and he was fine after that. I mean, he'll need to be on some ongoing treatment for his pre-excitation, but he's doing very well now. And it was all because his father was able to give him CPR at on the soccer field, and the ambulance officers were able to come and defibrillate him, but that was the cause. All right. Well, look, I think we've talked about today. I wanted to just go through a few different types of respiratory distress, and if you remember, the first one was children who had hyperinflation of their lungs, severe airways obstruction from severe bronchiolitis, and we talked about the different types of treatment you can give for that. The next one was a child who had tracheal compression and from an unusual cause, the PA sling, but we said that there is many other causes like lymph node compression or a thymic mass or a tracheal foreign body. And then we talked about air leak in a lung, and you can get why you can get air leak from anything that causes an intra-airway pressure or anything that damages the alveoli, like pneumocystis or pertussis or RSV or TB or laryngeal trauma. And then we talked a bit about an unusual cardiac problem of torsade de pois. All right. Well, I thought those cases were interesting, and they illustrate some interesting things that we don't always perhaps notice. And so I'll stop there and happy to answer any questions that you might have.
Prof, I had a question about management of PPP. Like when they're in a lot of distress, and we wanted to start septrin. When would it be a good time to start septrin? Because we only have the oral here.
Yes. Well, septrin is well. Sorry, septrin is well absorbed. Septrin is well absorbed orally, and so I think that in children that have those signs that I talked about, if a child's got failure to thrive and lymphopenia and air leak and severe respiratory distress and hypoxia, then of course I think if it looks like pneumocystis, then I would always start Septrin. But I guess we want to be starting it in children that have at a different threshold. You don't want to wait until they've got all the features like that child I mentioned has. And so I guess that if you have a suspicion that this child might have pneumocystis or might have HIV, then do a HIV test and see. I think that would be the way that you probably should approach it, really. That not start Septrin on empirically on every child who's got severe respiratory distress, but to have a threshold for starting it, have a suspicion of pneumocystis, pneumonia, and which might be based on the X-ray changes of the characteristics of pneumocystis, that bilateral fluffy opacity or air leak, or that the baby is HIV exposed or failing to thrive or has oral thrush. I mean, I think there's many different reasons why we might have a higher index of suspicion of HIV and pneumocystis. And I think that the key is not to start too late.
Thank you. I just had worries about starting it in a patient that has heart rates of 160, 170. Like, would we still give it through the NGT, or would we just wait?
I see, yeah. I would. I think it's okay. Why would you worry about it with a heart rate of 160 or 170, Benji? But through an NG tube, it's usually quite safe.
No, I was just uncertain, but thank you. I was just worried. Yeah. Like, we usually want to keep them nearby mouth, so I just wanted to.
I see. I think that in certainly for giving medications, I don't usually worry about the use of oral medications down a nasogastric tube in a child with moderate to severe respiratory distress. I usually treat them with medications down a nasogastric tube. You might keep them nil orally for other enteral feeding for a while, but I certainly don't have any problems with putting those types of medications down a nasogastric tube. I think the risk of aspiration is actually quite low in those patients. Yeah. If the nasogastric tube's in a good place. Okay, well, if there's no other questions, we might stop there. But I think it's been, I just wanted to go through those types of problems with you. And so, Eleni, do you have a question?
No, Prof.
Okay. All right. Well, thanks everyone for coming online for this teaching session, and I hope you all have a good week, and yes, get vaccinated.
Thank you, Prof.
Okay.
Thank you, Prof.
See you.
Thank you, Prof.